urinary problems. So the urinary system, the anatomy of it is actually quite cut and dry. You have the kidneys, you have the ureters, and you have the bladder. When it talks about the urine formation that starts in the kidneys, there is a lab called the GFR, the glomerular filtration rate. A normal GFR level is between 60 and 120. Kidney disease or acute kidney injury can fall between 15 and 60, and anything below 15, the patient needs to have dialysis done. So the structure again is your kidneys, your ureter, and your bladder. So when we're talking about nursing assessment history, what are you going to ask the patient? You can ask the patient if there's any family history, if they have any history of kidney or bladder issues, if there's been any changes recently in the volume of the urination, in the amount of times they're urinating, a change in the color or the odor. If they've increased any foods recently that could change the characteristics of the urine, and any medications that could change the characteristics of the urine. Skin color. Typically, if there's a skin color that has changed, it's going to start in the lower back where the kidneys are. If it's an acute kidney injury, which we'll talk about in a little bit, there could be a discolorization or a bruising. There could be edema if the kidneys aren't working well, if they're not pulling fluid out of the body to excrete it. The patient could have edema. They could have fluid in their lungs. This would be classified under the fluid volume overload. So their blood pressure could be high, their heart rate could be high, and their respiration rate could be high. RNs do not palpate internal organs. That's a MD or a nurse practitioner. Something we can do is actually something called CVA tenderness, costovertebral angle tenderness. What you can do is ask the patient's permission to touch them. Put one of your hands palm side to the skin on their lower back. Your other hand, do a fist. You do a fist. And then you can tap your fist to the back of the hand that's against the lower back. If they jump or they say that there is pain, that is a sign of kidney stones or some kind of inflammation or a blockage. Diagnostic studies for the urinary system. Urinalysis is something that most of us have probably had done. Technically, a urinalysis should be done first thing in the morning, but in the ER or urgent care, we're going to pull it whenever the patient comes in. A creatinine clearance, which is a 24-hour urine specimen collection. In a 24-hour collection specimen, that can be done in the hospital, but we do send them home with this. Education for sending them home is we need the urine to stay cool, not on ice, just cool. And when they get up in the morning, they should void in the toilet normally and flush it. And then after the first void, they should start collecting the urine. Something that might be done is a urine culture. So let's say you had a patient come in, they had a UTI, and they were pretty sick or they're elderly, so they were admitted into the hospital with IV antibiotics. And the patient just kept getting sicker. The physician may order a urine culture or a blood culture to see if it's gone into the kidneys. So now you'd have a kidney infection, or if it's in the blood, the patient's septic. So if your patient's getting antibiotics for a UTI and they just keep getting worse, this is a huge concern, and we've got to keep digging. Some other testing that might be done is a bladder scanner. Many of you have probably done a bladder scanner. It's just looking for the amount of fluid in the bladder. A KUB X-ray. This KUB stands for kidneys, urinary, and bladder. And we're looking for obstructions. We're looking for enlargements. And then occasionally during a KUB, we can do IVP dye. And the IVP dye is going to be able to show us if there's any narrowing. When it comes to IVP dye, though, we do need to know if the patient has a history of any type of shellfish allergy, because we would possibly give Benadryl or not give it at all if the allergy is too severe. To actually visualize the bladder, the physician could go into the OR and do a cystoscope or cystogram procedure. This is when we go up and actually can visualize the bladder with a small camera, and we can look again for fluid coming out of the ureters from the kidneys. This is how a physician would put stents in the ureter, and we can see if there's any type of tumor or mass growth growing on inside the bladder. Acute kidney injury. Acute kidney injury is something that just happened. Usually it's from some sort of injury or accident. The acute kidney has a rifle classification. I don't really want you to worry about that right now. So when there is acute kidney injury, we're looking at the clinical manifestations of right now. Remember, an acute kidney injury happened in the last 10 to 14 days. But even with treatment, the patient can have symptoms for up to a couple months. So we're going to ask, is there any urinary changes? Is the patient incontinent when they weren't before? So an example of that is if you have a woman that's had multiple babies, they can have some stress incontinence. They sneeze, they laugh, they can have a little stress incontinence. But when it's completely new to somebody that they're having some sort of incontinence, that is a sign of acute kidney injury. Did they take a lot of over-the-counter medication, specifically ibuprofen? And did they have an injury in the last couple days that they would like to talk to us about? This patient could have urinary changes because of it. They could have fluid volume overload. They could, if it's very severe, they could be in metabolic acidosis if when the kidneys aren't doing well. And they could have a sodium imbalance. So in acute kidney injury, the sodium actually tends to go down because the patient's getting washed out for a little bit. Potassium will go up. So in acute kidney injury, sodium gets washed out, so you see the sodium level go down, and you'll see the potassium level go up. We've already talked about the history. Then we're going to look at a creatinine, a BUN, a urinalysis, possibly a renal scan, or a CT. If the doctor still can't figure out what's going on with all that, he could do a renal biopsy. A renal biopsy is a physician procedure. So we don't have anything to do with it much until right after he's done, and it doesn't take long to do a renal biopsy. We typically do it under X-ray or ultrasound. We go in there, and he takes a little tissue out with a large bore needle, and we send it to pathology. We are going to incredibly closely watch this patient for the first couple of hours after a renal biopsy, because we're watching for any type of internal bleeding. The kidney area, the renal area in general, is very, very vascular. So we're going to be watching for bleeding. Remember, the patient's not going to be bleeding profusely. It's going to be that hematoma that we see. A little bruise getting bigger and bigger and bigger and wider. So what are we going to do? Going to be watching their vital signs. They typically are going to go home. We're not going to usually keep them in the hospital. We are going to want them to be doing a intake outtake record at home just to make sure to see how the kidneys are doing. Some of these individuals could need dialysis. There is a dialysis machine, which is a continuous dialysis machine. We'll cover that more in MedSurg 2. And we're going to be watching for mental status and level of consciousness with the fluid volume buildup and with the sodium being washed out. So we go to chronic kidney disease. Chronic kidney disease is a progressive ongoing. This is not something that happened overnight. It is a reversible loss of kidney function. So this patient is in a chronic fluid overload. We're going to be watching their BN and creatinine. It's going to be elevated even with dialysis. Hormones are going to be elevated. Electrolytes are going to be elevated with one exception. Very typically, the first stage of kidney failure, the sodium level is low. It gets washed out. We only see that in the beginning stage of kidney failure, that you'll see that the sodium is low. So let's talk about the different types of dialysis. We're only going to talk about two, and there's a third that's going to be introduced in MedSurg 2. So hemodialysis versus peritoneal dialysis. Hemodialysis is the one they have to go into the hospital or the dialysis clinic 3 days a week. They typically have some sort of fistula that has been surgically placed or a graft that the dialysis nurse can access. And then you have peritoneal dialysis, and this is done typically at home when the patient's asleep. So when it's a hemodialysis, now you can have physicians that put in large bore central catheters if this is going to be temporary, but if somebody is going to be having ongoing hemodialysis, a fistula or a loop graft is going to be the two of the main options. Now, regardless which one the patient and physician decide on, and sometimes it's just a physician preference, after the surgery, there's a couple things that we're going to be watching for. Now, I know in Fundies, you guys did the assessments for the throw of the bruise, but that's not the only thing we do, and it's not the only concern. We're going to be very closely watching the patient's radial pulse. We're going to be watching for CRT in the tips of the fingers and the nail beds. And we're going to be feeling for warmth of the hand. So if the patient's complaining their hand is cold and the circulatory rate in their tips of their fingers and nail bed is too high, and the radial pulse is either real weak or absent altogether, this is an emergency, and you have to let the physician know that we are calling the surgeon immediately because there's some sort of blockage, and very typically we do have to go in surgically and clean the blockage out. So pros and cons to peritoneal dialysis. They do have a lot more freedom. They hook up the dialysis at night, typically when they're sleeping. They are taught how to do sterile technique. They are taught how to use the machine because they're going to have this in their house. It is a cleansing of the blood, but it's not a complete thorough cleansing. So it's rare that you'll see this in like stage 5 or end stage renal disease. There's no vascular access. If the site is not taken care of, though, it can leak and it can be prone to infection. Hemodialysis is a complete, thorough cleansing of all the toxins and electrolytes. They're constantly being monitored by a nurse, and they're coming 3 days a week. Cons, it's a very strict diet. It is exhausting. There's a very strict fluid intake. And this is not a person that can just go and take off and do a week's road trip. It would be dangerous if they did that. Kidney transplants. So this data is from 2021, so it may have updated since then. But let's say it's 100,000 patients are currently waiting for a kidney transplant in the United States. About a quarter of those will receive a kidney. That's it. So post-op care. Pre-op care is going to be exactly the same as every other surgery we're going to do. So let's talk about post-op. Once the kidney is in, and by the way, we leave the 2 old kidneys in, so we just graft the 3rd one in. So after the surgery, a patient will technically have 3 kidneys. After the surgery, we're going to be really looking at electrolyte levels and fluid levels. The body may go into kind of a fight or flight mode where the body was unable to clean itself before, and now they get this new shiny new kidney. And the kidney might actually clean too well. So we could see the patient get dehydrated, so we're constantly going to be giving them IV fluids. And we could see the electrolytes imbalances go up and down. We're just going to let the body regulate this. So we're going to be giving IV fluids as needed. What goes in must come out. What goes out must go back in. And we're just going to be replacing or managing electrolytes as we need to. The body will calm down, but we just need to give it a couple days for it to regulate itself. This patient will be on immunosuppressant therapy. As you can see in the picture, the patient now has 3 kidneys. So if someone's on immunosuppressant therapy, we're looking for leukopenia. And specifically with the immunosuppressant therapy for organ transplants, we are watching for lipomas. So we're going to teach them how to palpate under their underarms and their axillary and around their neck for any types of new bumps that might show up. It is possible that the kidney could be rejected. So we're going to do a great deal of teaching for the patient with what rejection looks like, because it may not happen right away. It could happen years down the road. Right away, we could see when they're still in the hospital. All of a sudden, their temperature goes up, their blood pressure goes up, they're having some serious pain in the flank area where the kidney's hanging out. They get fluid retention back. Whereas someone where it's a chronic kidney rejection that can happen later, that's more of a gradual thing. And yes, the patient could be eligible for a second kidney transplant. So then they would have 4 kidneys. Right, benign prostate hyperplasia, better known as an enlarged prostate. The list of the most common signs and symptoms are there. I do want to specifically talk about the urinary tract infection. Now, the reason a patient would have a urinary tract infection is because of the backflow of urine that can't get out. So urinary tract infection is a sign of a prostate issue if they're constantly getting them. If they got a urinary tract infection once a year, that's not really a big deal. But if they're getting it chronically throughout the year, we got to look at that. And one of the most common signs and symptoms of urinary tract infection is cloudy urine. But cloudy urine is not a sign and symptom of benign prostate. Cloudy urine is a symptom of a UTI because there's an infection. There's a medication that has worked well to relax prostate muscles called Flomax. It also can relax bladder and urethra spasms, so that's why you could say males or females on Flomax. If the Flomax doesn't work or is not working well enough, the physician may opt for something called a TURP, a transurethral resection of the prostate. We go in and we cauterize the area of the prostate that's impeding the flow. This is incredibly, incredibly, incredibly bloody. There's going to be a lot of blood. So we do not want the patient taking their blood thinners. When they stop those blood thinners, that's depending on what the blood thinner is and what exactly is going on, but they will stop their blood thinners before the procedure. After the physician has done cauterizing, he's going to put a large bore Foley catheter in, and it's going to be a two-way Foley catheter. So one of the parts of the Foley catheter is going to be put into a 3-liter saline bag that we're constantly changing out. The other one is going to go into a large drainage bag. Think of just a really large Foley catheter bag. So this is a 3-way Foley catheter. After the surgery, there's going to be blood and there's going to be blood clots in the Foley catheter. There is going to be. We're just monitoring for how much. So the first day, there's going to be a lot of blood and blood clots. If you notice more and more blood clots or more and more blood, increase the IV irrigation. Open it up as much as you would like to, because you do not want anything coagulating inside the catheter or inside the bladder. After a day or so, when the blood and the blood clots start to go down, then we can decrease the irrigation. So more blood clots, more irrigation. Less blood clots, less irrigation. You'd only call the physician if the blood clots stopped the flow of the irrigation. So as long as it's flowing, as long as the irrigation's flowing into the bladder and coming out, there's no reason to call the physician. If it gets clogged, then we're going to call the physician. The last concept is gout. Now, as gout is a form of arthritis, it's actually caused from increased uric acid in the blood. For whatever reason, we see it in the big toe first. It gets inflamed, it gets painful, it gets puffy. Can be well managed. Sometimes it's a diet issue. Sometimes they need to decrease their acid in the diet, so that could be juices, that could be fruit, that could be red meats. And then there are some anti-gout medications that can be prescribed for this.